Good afternoon, everyone. Today we will be discussing Chapter 28, which is GI disorders and surgeries. Hopefully you completed the beginning of class activity. I just wanted you to read this short article and then to post a one-paragraph summary to Moodle for me to review. Then we will go ahead and move on into lecture, followed by your medical terminology quiz, and then you will have a short activity. I would like for you to look up a medication associated with the GI system. I want you to define the medication, tell me its classification, the uses of that medication, and any common side effects from that medication, and post your response to Moodle before the end of class today. You will have post-lecture quizzes. We will do those this coming Thursday. It'll probably be a Kahoot platform, and you will take those before you take your exam for this section. So today we're going to move into disorders of the GI system. The first thing we're going to discuss would be eating disorders. We did discuss anorexia last lecture, so I'm not going to touch on that this time. If you need to refer to the last lecture, please do so. Bulimia is another common eating disorder that is seen with the GI system. It is also thought to be psychological in nature. This is where the individual will binge on food and then they purge. This causes a number of issues for these individuals, including epigastric erosion, problems with dentition. Sometimes these individuals lose the plaque on their teeth from stomach acids that they are constantly vomiting. So these individuals would require a psychological evaluation. You would want to watch them for fluid and electrolyte imbalances. Starvation and death can also occur. So we would want to help these patients, again, through receiving therapy. They may be put on antidepressants, and then we would also need to monitor them, help them with behavior modifications. Another common disorder with the GI system is obesity. It's in fact the most common issue for GI disorders in America. This is when the individual exceeds more than 20% above their recommended ideal weight, or their BMI is greater than 30. Morbid obesity is when the individual exceeds 40% of their ideal weight. Approximately 3 million Americans are morbidly obese. So, like I said, this is an epidemic within America. It can cause complications such as cardiovascular disease. Diabetes can be a common result from obesity. Hypertension, high cholesterol, coronary artery disease, obstructive sleep apnea, cholelithasis, cancer, arthritis due to excessive weight gain, and increased susceptibility to infectious diseases. Along with that, they will have decreased wound healing. So to determine obesity, again, the BMI is greater than 30, or you can determine the waist to hip ratio. The waist to hip ratio measurement is just the waist measurement divided by the hip measurement. If the ratio exceeds 1.0 for men or 0.8 for women, this indicates obesity. Thyroid function tests may also be done to determine if the individual is in fact suffering from hypothyroidism. So treatment for patients who are obese will include counseling. These individuals will be recommended that they exercise and diet, possibly journaling, or keeping a diary of their exercise times and their diet choices. And then behavior modifications are also recommended. Stress management is adequate, and so are sleep. It's just helpful in achieving weight loss. If an individual's BMI exceeds 40, bariatric surgery may be indicated. Medications that might help to assist with weight loss would include orlistat, which inhibits the complete absorption of fats in the GI system. However, common side effects include diarrhea or an oily discharge from the rectum. So another option for these individuals would be phentermine. It's an anoretic drug. It suppresses the appetite, and it's been found to be safe for use for up to 2 years. These individuals will need close monitoring from their physician for any cardiac complications that may be associated with the administration of this medication. Older adults, we need to do some elderly consideration points here for the elderly and obesity. Elderly adults are at an increased risk for obesity due to their decreased metabolism and then their decreased sometimes mobility, either like due to chronic arthritis or chronic joint pain. So the less that these individuals are mobile, the more at risk they are for becoming obese. We discussed stomatitis and dysphagia in the last lecture, so I'm not going to hit on that this time, but please review the lecture if need be to get details about stomatitis and dysphagia. Oral cancer is a common disorder seen within the GI system. It first appears as discolorations or sores on the lips, the mouth, or the gums that do not heal within 2 weeks. Risks include genetic predispositions, cigarette smoking, chewing tobacco, pipe smoking, and chronic alcohol abuse are all common causes of oral cancer. Diagnosis is usually made through a biopsy. This biopsy is done just with the removal of a small portion of the tissue. It's sent off to the lab and observed for malignant cells. Treatment would include radiation, chemo, and then surgery if necessary. Some surgeries that are common with oral cancer include a mandibulectomy. This is the removal of the bottom portion of the jaw. A hemoglossectomy or a glossectomy may also be indicated if the cancer is found on the tongue, just depending on how much of the tongue the malignant cells encompass is how much they would take. So if the cancer spreads to the lymph nodes, a neck dissection may be indicated. If the individual does undergo this procedure, a tracheostomy will be placed to maintain that patient's airway. So post-op care for these patients would include closely monitoring for the airway, the breathing, and then the circulation. You'll want to make sure that they are, in fact, receiving adequate oxygenation to the cells within their body, so continuous SpO2 monitoring is necessary. They may also require cold compresses. We want to keep the head of the bed elevated to decrease any aspiration from any bleeding that may occur post-op and to keep the swelling down. And then wound and trach care must be provided frequently, as well as a consultation with a dietitian. So we'll move on into cancer of the esophagus. This one generally presents first as dysphagia with solid foods, and then it progresses all the way to dysphagia with just liquids. Other symptoms of this cancer include hoarseness, food regurgitation, foul breath, and persistent coughing. Risk factors for this disease include smoking, GERD, chronic alcohol consumption, are all risk factors for the development of esophageal cancer. So pain would be a late sign of esophageal cancer. It's usually substernal within this region, or it may radiate to the back and occurs upon usually swallowing. Weight loss is also common with these individuals. This disease is confirmed through an EGD and a biopsy once they are in the place where the malignant cells are present. So we didn't discuss an EGD very thoroughly last class period. I know I had you guys post your GI diagnostic test to Moodle. When an individual undergoes an EGD, after they are in recovery, the main thing to monitor after you ensure a patent airway would be to monitor for the return of the gag reflex. This individual's throat is numbed before the procedure begins, and so the inability to swallow is present, and you need to monitor for the return of gag reflex before you give these individuals any kind of ice chips or liquids or food. They need to be monitored for that return. If they don't have a return of gag reflex, it is highly likely that these individuals will aspirate. So treatment for esophageal cancer includes ablation of the malignant area, which is just the burning of that malignant tissue at that specific site, or an endoscopic mucosal resection may be necessary. And then rarely an esophagectomy is performed, where there is a portion of the esophagus removed and then it's replaced and reconstructed with a portion of the stomach. For advanced stages of esophageal cancer, palliative care is usually indicated, meaning that these individuals are just receiving care for comfort, not for sustaining life. So these patients might receive radiation, they may receive chemo. We may dilate their esophagus if they have strictures to their esophagus, making it difficult for them to swallow. If they're experiencing dysphagia, we may go ahead and dilate their esophagus, or we may actually place stents within the esophagus to keep that area opened so that discomfort is lessened for these individuals. Nursing care would include maintaining a patent airway again, ensuring adequate O2 exchange, maintaining proper nutrition, promotion of wound healing, and then pain mitigation. The head of the bed should be raised whenever these individuals are eating. If a feeding tube is present, this needs to be probably in place for several weeks, and then observation for infection need to be closely monitored. Signs of leakage from the feeding tube would include severe pain, fever, and dysphagia. If these symptoms arise, you need to notify the physician or the surgeon immediately. Next, we're going to discuss hiatal hernias. Hiatal hernia, it's a defect in the wall of the diaphragm where the esophagus is protruding into the thoracic cavity. Women are generally at a higher risk for developing hiatal hernias than are men. Risk factors also include loss of muscle tone, obesity, multiple pregnancies, there again reducing the muscle tone of your abdomen, and congenital defects may also be a cause. Common signs and symptoms include acid reflux, in which indigestion and belching, and then epigastric or substernal pain are present. Nighttime coughing may occur with these individuals as well. The diagnosis is done through an upper GI series. And then treatment would include weight loss or the deterring of gaining any further weight, loose-fitting clothing, antacids, histamine receptor antagonists, or proton pump inhibitors. You'd want to keep these individuals' heads of the bed elevated 6 to 8 inches. This could relieve acid reflux. And then these patients should abstain from eating 3 hours prior to bedtime. And they need to avoid alcohol, chocolate, caffeine, fatty foods, smoking, and heavy lifting. We're going to move on into GERD now. GERD is known as gastric esophageal reflux disease, but this is not a disease, it's in fact a syndrome. The reflux of food and stomach acid occur, and they move up into the esophagus where the loss of the esophageal sphincter is present, so this allows that liquid, the food particles, and the stomach acid to then reflux into the esophageal area. Delayed emptying of the stomach might also be a cause, and then certain foods and medications may also lead to GERD. It's important to note that 90% of patients with GERD have a hiatal hernia. So patients with hiatal hernias need to be closely monitored for signs and symptoms of GERD. These symptoms include dyspepsia, reflux, chest pain, coughing, dysphagia, belching, flatulence, and bloating after eating. Lying down exacerbates these symptoms, so we want to keep the head of the bed elevated for these patients as well. Other nursing care includes education on weight loss, avoidance of aggravating foods such as spicy, acidic, or caffeinated foods or beverages. And then we need to avoid high fat and oily foods. They would be instructed to eat small, frequent meals throughout the day. They need to chew their food slowly and thoroughly. And then medications used to treat GERD include H2 receptor antagonists, proton pump inhibitors, and prokinetic medications. All right, next we're going to discuss gastroenteritis. This is the inflammation of the stomach and small intestine. It's caused by a virus, a bacteria, or a parasite. The signs and symptoms include vomiting, diarrhea, abdominal cramping, distension, fever, increased white blood cells, and blood and mucus in the stools. Patients need to be NPO until vomiting stops. Stool studies may also be indicated to identify the cause of the gastroenteritis, and then we would treat that after we identified the cause. Next, we'll talk about gastritis. Gastritis can have acute or chronic forms. Both are the inflammation of the lining of the stomach. Atrophic gastritis involves all layers of the stomach. It's currently seen in patients with gastric ulcers and cancer of the stomach. If it goes untreated, it can result in ulcer formation and GI upset. Causes include H. pylori, other bacteria, viruses, parasites, excess alcohol intake, contaminated foods, cocaine use, and certain medications can also be a cause of this disorder. Chronic gastritis, it usually presents when it's chronic gastritis due to renal failure. It usually has no signs and symptoms until suddenly this patient has a massive hemorrhage that occurs. This is an emergent situation. They would need surgical attention immediately. Signs and symptoms of just regular gastritis include anorexia, nausea and vomiting, pain, tenderness, hiccups, diarrhea, and then, like I said, occasionally massive hemorrhage can occur. This is diagnosed through endoscopic examinations again, and then the nursing care of acute gastritis would include placing the patient on NPO status and administration of medications that decrease GI motility. We'll want to monitor these patients for fluid and electrolyte imbalances, so you may include a glucose electrolyte solution for oral administration to help to avoid the fluid and electrolyte imbalances. If that is not able to be tolerated, then we may just go ahead and start IV fluids as necessary. Treatment would include administration of antispasmodics, antacids, H2 receptor antagonists, and proton pump inhibitors. We need to eliminate the use of NSAIDs. We would also encourage milk and milk product consumption to help with nutritional status. Other products that may help with nausea would be ginger or peppermint. Dietary changes such as eliminating spicy and acidic foods is necessary, and then lifestyle changes if indicated. Treatment for H. pylori itself includes amoxicillin, clarithromycin, and then proton pump inhibitors for 1 to 2 weeks. Flagyl may be substituted for amoxicillin if the patient is allergic to penicillin. So next we're going to move into discussing peptic ulcers. These are a loss of tissue in the upper GI tract. They occur when the mucosal lining of the stomach is not effective in guarding against erosive substances. 90% of these have been associated with H. pylori. Other causes include malnourishment, prolonged psychological stress, aspirin and NSAID use, biphosphonates, alcohol, glucocorticoids, and then genetic risk factors. Common signs and symptoms are pain that subside after the ingestion of food, epigastric pain that worsens throughout the day, nausea, anorexia, anemia, and weight loss are other common signs and symptoms. Diagnosis, again, is done through an EGD or an upper GI series. At this time, the individual will also be screened for H. pylori. These ulcers are first treated with medications such as antacid, proton pump inhibitors. We will try those first, and then if it is not effective, an NG tube might be placed to empty the stomach contents and to decrease vomiting. And then surgical treatment might be indicated when chronic ulcers do not respond to medications, or if a perforation, obstruction, hemorrhage, or malignancy occur. 3 major complications from peptic ulcers include, the first one we'll talk about is hemorrhage. This happens when the vessels of the stomach are eroded. Signs include vomiting of blood, weakness, feeling faint, restlessness, thirst, mental confusion, and diarrhea, often a maroon or bright red color, or sometimes even black in color. If this is not treated immediately, hypovolemic shock will ensue and the patient will die. 20% or more of the total blood volume has to be lost for hypovolemic shock to occur. So specific shock symptoms include diarrhea, hypotension, tachycardia, throaty pulse, elevated white blood cells, and elevated BUN. And then the H&H will actually decrease. The patient needs to be stabilized with IV fluids and medications, and procedures such as an EGD are performed to locate the source of the bleed, and hopefully it's stopped. For chronic peptic ulcers, a classic sign is sudden and severe pain that radiates to the shoulder. Perforation is actually the cause of that symptom. So if perforation occurs, often it, again, presents as sudden and severe pain that radiates to the individual's shoulder. This is complete erosion of the GI wall. The stomach contents leaks into the peritoneal cavity and can lead to peritonitis and sepsis. This is considered also an emergency situation. The abdomen will be rigid and tender, and shock will ensue if it's not corrected immediately with surgery. And then the last complication is obstruction. And that occurs as a result of scarring and loss of muscle tone to the pylorus, and persistent vomiting ensues. Treatment would include placing an NG tube, keeping the patient in PO, and surgical correction. Let's discuss gastric cancer now. Gastric cancer, the exact cause is not known. However, we do know of risk factors linked to GI cancer. These include diets high in smoked, highly salted, and spiced foods. Preservatives such as nitrates and nitrites are also associated with gastric cancer. H. pylori and genetic factors are also linked to this type of cancer. And then specifically individuals with a blood type A are at a higher risk for GI cancer. This cancer, it grows within the mucus glands of the GI tract. It's first seen as an ulcerative lesion with irregular borders and raised margins. The tumor generally metastasizes to the lymph nodes, the liver, and then the ovaries in females. Signs and symptoms of this cancer include indigestion, loss of appetite, nausea and vomiting, weight loss, belching, paleness of the skin, fatigue, weakness, dizziness, and shortness of breath. These signs do not often occur until the disease is very, very progressed. So anemia is also present for these individuals generally. An EGD and the presence of tumor markers are the diagnostic procedures for gastric cancer. Treatment would include surgical debulking of the tumor, a pyloroplasty, a vagotomy or gastric resection may be indicated, and then lymph node dissection may also be necessary. Chemo and radiation may be used, and generally there's only about a 40% 5-year cure rate for these individuals. Common therapies for the GI system include gastrointestinal decompression, which is the insertion of an NG tube into the patient's GI tract via one of their nares, and the placement is to alleviate excess fluid and gas. There are several different types of NG tubes. The first one is a Levine tube. This is used to release pressure in the stomach, so it's the shortest of the NG tubes. Miller-Abbott's, Cantor, and Harris tubes are used in relieving pressure in the small intestines. And then a Salem tube is also used for decompressing the small intestines. It's actually the preferred tube of use. It has a blue air vent attached to it that helps to prevent damage to the intestinal walls. Nursing care for patients with NG tubes would include the fact that the shorter tube, the Levine tube, needs to be set to low intermittent suction, while the longer tubes are set to a low continuous suction. We need to ensure that these patients remain in a Fowler's position to help avoid aspiration of stomach contents. Irrigation of the tube must be performed as ordered with normal saline. The amount of irrigation needs to be accounted for on their I&O sheet, as well as the output from the tube itself needs to be accounted for on the output side of their I&O sheet. The appearance of the drainage needs to be monitored frequently. You'll monitor them for fluid and electrolyte imbalances, and as well as nausea and vomiting, feelings of fullness or bloating, shortness of breath, increase in abdominal circumference, and monitoring for blood in the output. We'll also monitor for complaints of discomfort such as nair pain, sore throat, dry mouth, and ear aches and dry lips. So frequent oral care is necessary for these individuals, as well as providing humidification. And then if it is ordered by the physician, sometimes these individuals may have small amounts of ice chips, small sips of water, hard candy, and chewing gum. Once the NG tube is DC'd, it's important to monitor these patients for the return of GI symptoms. So next we'll discuss enteral nutrition. It involves the insertion of a nasoduodenal tube into the patient's duodenum to deliver nutrition to the patient. The end is weighted, and the tube has a radiopaque lining running the length of the tube, so that proper placement can be confirmed by X-ray. This tube may only be placed by a physician or an RN. It's measured every shift to detect dislodgement. Feeding may be continuous via a pump, or it may be intermittent on a schedule, ensure to deliver the appropriate amount of calories per day to the individual. We may also administer medications through the feeding tube. However, medications are never, never, never to be crushed and mixed with the patient's formula. This will obstruct the tube and it will have to be removed and replaced. Patients who require long-term feeding may have a PEG tube placed instead of just a nasoduodenal tube. Again, this tube is measured at least daily to ensure the proper placement. The stoma of the PEG tube must be monitored for infection, and it must be cleaned with soap and water every day. A 10 cc or larger syringe must be used in the assessment of residual feedings for these individuals. So either with the nasoduodenal tube or a PEG tube, you have to use a 10 cc or larger syringe. Residual is checked to observe for delayed gastric emptying. And then also the formula bags for these patients need to be changed every 24 hours. And then flushing needs to occur every 4 hours with 30 milliliters of water. And then another type of feeding tube is known as a jejunostomy. It'll be sutured in place, and this tube rests in the jejunum. It must also be measured daily to ensure the proper placement, and sutures must be monitored to ensure that they are in place. So we'll very briefly discuss some GI surgical procedures that are commonly seen. Some of those include bariatric surgeries. This reduces the size of the patient's stomach. It can either be a restrictive type, a malabsorptive type, or the combination of the two. The restrictive surgeries include adjustable gastric banding. It's where a band is placed around the fundus of the stomach, and it reduces the size of the patient's stomach. This can be adjusted as needed as the patient loses weight. A malabsorptive procedure commonly seen is a Rooney gastric bypass. It limits the stomach size, and it bypasses the duodenum and the jejunum, which eliminates the absorption of calories for these individuals. A gastric sleeve is also commonly seen. It's known as a biliopancreatic diversion with a duodenal switch. A vertical sleeve gastrectomy removes half of the stomach and reduces the production of the hormone ghrelin, which reduces appetite. So complications seen with these procedures include leakage of the stomach contents into the peritoneal cavity, dumping syndrome may be seen, and then respiratory and cardiovascular complications are commonly seen with these procedures. Gallstones are often another common side effect because of rapid weight loss. Nutritional deficiencies can occur for these patients, and they usually need to take supplements for the remainder of their life. So signs and symptoms of complications would include abdominal pain, nausea and vomiting, tachycardia, fever, hypotension, weakness, sweating, and diarrhea. Post-op care for these patients may include the placement of an NG tube, which should not be repositioned ever, because we do not want to disrupt the sutures. Feedings are scheduled by a dietitian, and then sugars are to be avoided altogether because concentrated sugars can lead to dumping syndrome. For the first 2 months, the calories are restricted to around 300 to 600 calories per day, and then that is increased gradually to 1,000 calories per day, and that's usually where it stays. These individuals are also encouraged to keep an exercise and diet diary. And then let's talk a little bit about surgical procedures for peptic ulcers and GI cancer. These include a pyloroplasty with a truncal or proximal gastric vagotomy, a subtotal gastrectomy, and then a total gastrectomy. So a pyloroplasty is the widening of the pylorus, and the vagotomy is selectively severed, which decreases secretion of stomach acids. A subtotal gastrectomy is the removal of part of the stomach and then the rejoining of the remaining portion to the small intestine by anastomosis. A total gastrectomy is the complete removal of the stomach. The esophagus is simply just anastomosed to the small intestine itself. These individuals are at a very, very high risk for dumping syndrome to occur. So pre-op care for these patients will include a liquid diet the day prior to surgery, and then they will be kept in PO after midnight. They'll also undergo a bowel prep the day before surgery to clear the GI system of contents and bacteria within the GI tract. Post-op care for these individuals, again, will include handling the NG tube with very, very gentle care to avoid dislodgement. And then after the removal of the tube, liquids are then introduced into the diet in small amounts to determine patient's tolerance. And then we gradually increase those as tolerated. Within the first 6 months, patients are expected to tolerate 3 small meals a day. And then patients who have had a total gastrectomy are given frequent small semi-solid meals for the rest of their lives. It's important to note that medication effectiveness for these individuals may also be altered, and the absorption of the medication may not be the same. So we need to monitor for signs and symptoms of the return of some other disorders that these individuals may have been receiving medications for. Dumping syndrome, like we talked about, it's the rapid passage of large amounts of stool and liquid into the jejunum itself. These signs and symptoms include nausea, weakness, abdominal pain, diarrhea, perspiring, heart palpitations, and then nursing care will include educating the patient to eat small meals with minimal fluid intake, sometimes no fluid intake with their meals at all. Sugary foods should be totally eliminated from their diet, and it may help the patient to lay flat for 30 minutes after the ingestion of food. Paralytic ileus is also another common complication from GI surgeries. This is the stalling of peristalsis within the GI system. Signs and symptoms include absence of bowel sounds, abdominal extension, and no passage of flatus. These individuals will be kept in PO until the return of bowel sounds, and then the diet is slowly introduced back to the patient. So they will start on clear liquids. Once that is tolerated, they will move to nourishing liquids, and then soft pureed foods, and then possibly a solid diet. That pretty much concludes chapter 28 for us. I want you all to, again, complete your activities that are assigned for today. And then next class period, we are online again. We will start the day with most likely a Kahoot quiz over chapters 27 and 28, then followed by your exam 4. And then I will go ahead and probably post the lecture over chapter 29 for you all to review. So those will be your assignments for next class period. I have posted a study guide for this lecture on Moodle for today, so please follow along with that while you watch the lecture. And I will see you all next class period. Take care and have a good afternoon.